or intensive care unit. Our objective is why to use sedation, because once a patient is admitted to intensive care unit, they feel that they are very sick, and hence they are admitted into the intensive care unit, where sometimes the patient are admitted in an intensive care unit because they are not critically ill, but they need some extraordinary care. Second one, which one to choose? If we have to use an sedation and if we have to use a neuromuscular paralysis agent, which one is the best for that particular patient? Sometimes it is very difficult to make a decision, but we will be talking about it, when to use a sedation and where to use neuromuscular paralytic agent. How to use the drugs? The drugs that are used, most important is that what is the route it should be given to them so that they get best effect with the minimum dose and the very good effect as desirable by the internist. Interventionist also had to use it sometimes to make the patient go to do the procedure smoothly and not to go for any trouble while either anxiety or any other problem that a person can have while doing some procedures. What are the problems? The patient can have a problem and the internist can also have a problem, either in a form of the patient, if we want to sedate a patient, the patient may have some disorder that are concerned with the metabolism of the drug, and sometimes the patient usually are not very cooperative, hence a sedation is used, and sometimes the patient is very cooperative but the problem with the physiological problem that come into action, and therefore a neuromuscular paralytic agent is also needed. What protocol should be followed? We should have a very good protocol so that every patient is undergoing sedation very smoothly and coming out of it very smoothly, and we have to use a minimum dose with the best route of administration, and neuromuscular agent, when they are used precautionally so that there is no harm done to the respiratory system, as diaphragm is also part and parcel of neuromuscular, and it should not undergo any problem so the patient doesn't end up into respiratory distress. What is meaning of soothe? Its meaning is to soothe. Now, sometimes a soothing words can be very meaningful to a attendant and to the patient who is admitted, and sometimes this soothing effect can be brought up by proper explaining and properly telling them that what are we doing is for the benefit of the patient and it's not going to harm them at all in any form, whatever it may be. And it is not going to make the patient deteriorate, but this is make the patient more comfortable and will help in diagnosis and management of the patient, and the outcome would be better. It is our duty as an internist that all the patients require some kind of soothing effect. As I've already taught, it may be in a form of words or it may be in form of drugs. Why we need sedation? Anxiety. Once a patient is admitted to either in the ward or in an intensive care unit, there is an anxiety. What is happening? What is going around him and what is going with him? Otherwise, the patient feels that there are so many patients in wards and they have different problems. The anxiety is that whether the patient will be all right, what will happen. These are the usual questions that are asked by the patient and their attendant, and hence a sedation is needed. Second is pain. Pain is a very important somatic disorder that brings a patient to the hospital. It may be mild pain or it may be severe pain. When it is there, the patient sometimes can bear it, and hence they can be explained that this is not going to kill them, or this is not going to, it is not a pain that will take away their life. But at times it is very, very difficult. The pain is so severe, as we see in patients who are suffering from acute pancreatitis, myocardial infarction, and they need some sort of a sedation so that their pain is relieved and they feel better, and other procedures and other medication can be done very easily. Second thing, acute confusional state. This is one of the most important cause, that a patient who needs sedation, they are badly confused. What is either from point of view of their disease, or from point of view what will happen to them. Second thing, when a patient needs mechanical ventilation, they need some sedation so that any procedure that is going on, when if we had to intubate the person, then we can do it very smoothly, and there is no trauma to the trachea, to the oral cavity, and any other organ that, if we want, even teeth and tongue are not disturbed by this mechanical intubation period, and the procedure is smoothly going on, and the patient usually if on ventilator can tolerate the intubated tube very well. It may be a part and parcel of treatment or a diagnostic procedure. Patient who come in hallucination, or patient who are very, very excited, it is for them, it is alcoholic withdrawal. Sometimes sedation is needed as a part of treatment. Some diagnostic procedures, such as minor biopsies from the skin, sometimes for peritoneal or pleural paracentesis, diagnostic procedure can be done under very low sedation, and the result will be very, very good, where there will be no other problem as such. If the patient moves, patient is usually feeling better, and the procedure can be done very smoothly, and the diagnostic reports are very, very as per desired effect. Psychological response to stress. Once a patient gets some disease, they use and admitted into the ward, they have got some psychological stress, that what would be the outcome? Will they come out with order with this? Will they able to have a normal, healthy life after that? So these are certain things that we also need for sedation. Stress response to pain. How does a stress response to pain? Pain is a very, very important parameter that brings a patient to the hospital. The most important is tachycardia, where the heart rate from the baseline rises up to 20 to 30 beats per minute, or it is if not recorded previously. Tachycardia is usually taken as when the heart rate is more than 100 heartbeats per minute, and 100 pulse rate 100, more than 100 per minute. Stress increases myocardial oxygen consumption. When there is a demand for myocardial oxygen consumption, the patient can also, after sedation, the demand can decrease. There is hypercoagulability. In this condition, we also use sedation. Immunosuppression. There is immunosuppression. When the patient is under stress, it's one of the most important cause of stress, and stress is one of the most important cause that leads to immunosuppression. What does it do? Analgesia. Analgesia means we want to make a patient free from pain. Anxiety. Patient when sedated, anxiety is decreased. Dyspnea. Difficulty in breathing is called dyspnea. When the respiratory rate exceeds from 12 to 24 per minute to more than that, up to 30 or 36 breaths per minute, this is called dyspnea. And this is the indication for sedation. But we should also take care that there is no deprivation of the respiratory center, as some sedative agents called depression of the respiratory center, and they may need further management. So the dose should be adjusted so that there is no respiratory depression. To facilitate the care, once a patient is admitted, this will also help them to manage better if this is done. When anxiety is there, there is increased oxygen consumption, and hence when we sedate a patient, it will also decrease the oxygen consumption, as we want in myocardial infarction. To achieve amnesia, the patient who are violent and they are talking irrelevantly, they can have a better achievement with sedation, so that others are not disturbed and their family members are not disturbed and they themselves are not disturbed, and can have a smooth outcome of the medication. What should be the ideal sedative? From our point of view, it should have a rapid onset of action and rapid recovery without any complication. There should means that it should act as early as possible, and once we have completed with the procedure, the recovery should be very, very rapid. No drug accumulation. There should not be any accumulation of the drug, and especially it should be seen that if any drug that is metabolized into the liver is functioning normally, and there is no hepatotoxicity. If the drug is excreted through kidneys, we should see that there is the glomerular filtration rate is good, and hence the drug is not accumulated into the body and easily excreted either through the bowel or through the kidneys. The third property, be easy to titrate. We should be in a position to use the minimum dose, and then we can titrate it if at all needed to increase or to decrease. We can start with a higher dose and can titrate it to, if the patient starts undergoing sedation, we can make it go into the lower dose and minimum dose is achieved. It should not cause tachyphylaxis or withdrawal symptom. Tachyphylaxis is defined as once a drug is used and then its effect by repeated administration decreases. And there should not be any withdrawal symptoms. Sometimes the drug may be used, what we have used can have some problems such as vomiting or some other withdrawal symptoms. No hemodynamic instability. Whatever the sedative once used, it should not compromise with the hemodynamic, especially when it is used for a patient who are not hemodynamically stable. If the patient are hemodynamically stable, this drug are usually very, very effective and leads to a very, very good response as desirable. The cost is also very, very important. Any patient who are insured, this may be in material, but patients who are not insured or don't have any aid which is leading for the price, we should not compromise if at all it is needed, but we should always keep into our minds that the patient doesn't have to have spent a lot of money just for a small thing, and it should not be very, very expensive, but even if it is cheaper, it should be very, very effective and should lead to a good desirable effect as needed at that particular time. But as we all know, all drugs, no single drug has all these properties, combination of drugs. At times it is not very easy to achieve the desirable effect, and because there is no ideal drug, and we had to use a combination of one or two drugs or multiple drugs to achieve the desirable effect. Approach to sedation and analgesia. Define the problem. Identify and treat underlying abnormalities. We should also know what is the problem the patient is facing in thoroughly. Does he is in really need of that sedation that we are going to use? Identify and treat underlying abnormalities. We should first treat the underlying abnormalities, such as in case of myocardial infarction, with the pain. If we want to sedate a patient, we should also manage what the coronary thromboembolism has occurred, and hence we should also treat this it is similarly by using any thrombolytic agent. The underlying abnormality should not be neglected and it should be given the priority. Estimate the duration of treatment required. If we are using any sedation or analgesia, we should also know how long we are going to use it. What would be the outcome? The long duration sedation may not have a very good result on the patient outcome. We should always choose an appropriate drug. We should always prefer a drug that is most effective, most indicated in that particular disorder, and is excreted and metabolized fast when we want to wean the patient off from sedation and analgesia. Therapies. There can be two therapies. One is what we call as non-pharmacological and another is pharmacological. The non-pharmacological therapies are we can counsel a patient and explain them that they are not in danger and they will have a very good outcome of the disorder and they will be discharged from the hospital without any sequelae. If at all there will be any problem, that can be treated and managed properly by any physician whosoever present there. And even the person who was taking care of that patient, that they are counseled and they are sometimes words better than what medication do. This is what we at times have to use, and this works very well in some patient. The confidence of the doctor and the confidence of the patient in the treating physician is a very, very important factor in that condition. Pharmacological. Non-pharmacological, avoid distressing situation. We should not cause any distress situation. Allow adequate access of caring visitors. Maintenance of good communication with the patient. Positive body language. Ice chips of mouth. Comfort mattress. Relaxing music. Maintain daytime and nighttime involvement as best as one can. Establish normal sleep cycle in all patients who are admitted, whether into the wards or into the intensive care units. Definition. Now, who needs this? Delirium is an organic mental syndrome, acute and potentially reversible impairment of the consciousness and cognitive functions that fluctuates in severity. It can be hyperactive or hypoactive, and hypoactive is more dangerous as compared to hyperactive. Method of a scale delirium. CAM, Confusion Assessment Method. ICD-SC, Intensive Care Screening Checklist. Sedation. Now we say we are going to for Richmond agitation sedation scale. The score, if we score, the score is 4 plus 4, combative, overly combative or violent patient, immediate danger to the staff, self or to the attending personnel. 3 plus, very agitative, this is 3 plus, puts on a removable tube. Patient starts removing tube, catheters or agitative and has an agitative behavior toward himself or to the attending physician or family. 2 plus 2 agitated, frequently non-purposive movements or patient ventilator asynchronicity. Patient is put on ventilator and is not permitting it. There may be sometimes that the patient is tolerating it well and sometimes they want to remove and there is an asynchronicity. There will be asynchronicity. One point is restlessness, anxious or apprehensive, but movements not agitative or violent or vigorous. Zero, zero sedation, zero score is patient is alert and calm and is able to is readily accepting whatever is given to him and is on ventilator very normally or tolerating all the medication either IV or RT or any other. -1. Patient is drowsy, not fully alert but awake by 10 seconds with eye contact to voice. Once we are call them by name or by any other verbal command, they open up the eye and they respond and they have got eye to eye contact. -2. Light sedation, briefly awake less than 10 seconds with eye contact to voice. The patient responds with the eye opening and has an eye contact with the person who is calling but only to the voice and it is less than 10 seconds. -3. Moderate sedation, any movement but no eye contact to the voice. They only make a movement but there is no eye contact and there is no to the voice but there is no eye contact. Deep sedated, it is scored as -4. No response to voice but movement to physical stimulation. If the patient is touched or given a slightly painful stimulation, the patient only causes movement but there is no response, neither it open the voice, open the eyes or there is no eye to eye contact. Unarousable, no response to voice or physical stimulation. This is -5. To determine the RAS process as follows. Step 1. Observation. Observe the patient without interaction. If the patient is alert, assign the appropriate score 10 or plus 4. If the patient is not alert, go to the step 2. Now what is step 2? Step 2 is verbal stimulation. Address patient by name in a loud voice and ask if the patient to look at you, can respond, can repeat once if necessary. If patient respond to voice, assign to appropriate score as -1 to 1.3. Okay. Assign appropriate score as -1 to -3. If this is not respond, go to the step 3. Step 3 is physical stimulation. Shake the patient's shoulder. If this is not responsive, rub the sternum vigorously. Assign the appropriate score as -4 to -5. Now, table Rickers sedation agitation scale, SAS. This is called SAS. Pulling at tube or catheter, climbing over the bed rails, striking staff, and requires restraint and frequent verbal clues, being endotracheal tube. Anxious and physical agitation, calm by verbal instruction. Second, calm early, arousable follows commands. Once you ask them to do something, the patient is calm and follow whatever command you give. Third, difficult to arouse but awakes to verbal stimulus or gentle touch, followed by simple command but drift to again the same state. 2. Arouse to physical stimulus but it does not. communicate or follows command, moves spontaneously. 1. Minimal or no response to noxious stimulus, does not follow command. A noxious stimulus may be given, such as pinprick, but the patient doesn't respond and it doesn't follow the commands what you give. Richmond's agitation sedation scale, RAS. Comparative, violent, dangerous to the staff. +4. Pulls, +3. Pulls off or removes tubes, catheter, even RT which is put, and IV fluids, or especially the catheter, Foley's catheter, enduring catheters. Is aggressive. +2. Frequent non-propulsive movement, fights with the ventilator, tries to pull out the tube that is put in. +1. Anxious, apprehensive but not agitative. 0. Alert and calm, follows all commands and is calm and do whatever is asked to do. -1. Awake to voice, eye opening and contact is there for more than 10 seconds. -2. Light sedation, briefly awaken to voice, eye contact is there and it is for more than 10 seconds. -3. Moderate sedation, movement of the eye opening, no eye contact, but there is no eye contact. -4. Deep sedation, no response to voice. The patient doesn't respond when you call them by name, but movement of the eye is there and is opening to physical stimulus. Once they are touched over the shoulder, or they usually respond. -5. Unarousable, no response either through voice or the physical stimulation. Sedation scale, modified Ramsay's sedation scale. Awake, arousable, agitates, restless. 2. Awake, cooperative, oriented, serenus. 3rd. Awake, responding only to commands. 4. Asleep, brisk, respond to stimulus. 5. Asleep, sluggishly respond to stimulus. If you ask them something, they respond in yes or no, but the response is not complete. 6. Asleep, no response to stimulus. Richmond's agitation scale, RAS. Score, assignment and description. +4 is combative, overall combative, violent, danger to the staff and observation. +3, very agitative, pulls up, remove tubes or catheters, agitative and observational. +2, agitated, frequent non-purposive movements with observation or disharmony with the ventilator or any other support. +1, restless, anxious, apprehensive but not agitative. 0, alert and calm on and is observing everything normally. Drowsy, very loud speaking, voice awakes, it is less than 10 seconds, not fully alert. Light sedation, when loudly speaking, voice briefly awakes to the voice, but it is less than 10 seconds and there may be eye contact. Moderate sedation with loud speaking voice has movement of the eye without any eye contact. Deep sedation, movements to physical stimulus when touched on the shoulder or rubbed, they respond by movement, but there is no eye opening and there is no eye-to-eye contact. Unarousable, no response to physical stimulus at all. Sedation strategies. Goal-directed sedation, patient-targeted sedation, daily interruption of sedation, intermittent sedation, analog sedation. Now we'll be talking about what should be our goal. Now, the behavior pain scale. This is what we are always using. The facial expression is very, very important in all the patients whom we are trying to find out the pain for the pain scale, especially when sedation is used for pain. Facial expression. Relaxed, the score is 1. Partially tightens, the face grimps. Partly tightened, the score is 2. Fully tightened, score is 3. Grimacing, the patient is grimacing and making face that it is not bearable to him, the score is 4. Now, upper limb. There is no movement of the upper limb, score is 1. The upper limb are partially bent, the score is 2. The patient fully bends the upper limb and the fingers are flexed. The score is 3. Permanently retracted. The upper limb is permanently retracted. Compliance with the ventilator. Tolerate ventilator well, score is 1. Cough but without tolerating with ventilator, score is 2. Fighting ventilator, score is 3. Unable to control ventilation, the score is 4. Total score 1, no pain. 1 to 5, accept pain control. Now, initiation available agent. Analgesics.